Thank you so much for having me. Thank you to John Varga for asking me to come. And let me just say what a pleasure it is to be speaking to the Chicago chapter of the Scleroderma Foundation. What a large and engaged group. This is really wonderful to see. I'm just happy to be here. So we're going to talk a little bit about biomarkers in scleroderma and really kind of what they are. We're going to start from there and really how we could use them in scleroderma. They are being investigated actively, and you heard a little bit about that today when Dr. Denton was talking about clinical trials. But we're going to talk about the various ways they could be used and how that might help us in the future. So what I'd like to start with is just what the concept is of a biomarker, how we define it, and ways that we could use it. And then I'm going to walk through a few patient scenarios and walk through different aspects of the disease, like the diffuse skin disease and lung fibrosis and vascular disease, and kind of discuss where we have existing biomarker data, and then explore areas where we probably could do better and we could use biomarkers more effectively. So what do we mean when we say biomarker? So biomarker stands for a biological marker. What does that mean? This means some measurable characteristic of some biologic process. Not necessarily a process going wrong, but any biologic process, a normal biologic process or an abnormal biologic process. So that means in a disease or not necessarily in a disease. This is a kind of a peek inside to look at what we can't see by looking at a patient. Now sometimes when we're doing clinical trials, we have what's called a clinical endpoint. So what does that mean? That means the thing we are going to measure that tells us if a patient is responding to a drug or not. And a clinical endpoint is what the regulatory agencies like the FDA want to see. And what does that mean? That reflects how a patient feels, functions, or survives. So for us to go to the FDA and say, we think this drug's help patients with scleroderma, they want to see that patients with scleroderma feel better, function better, survive better. What a biomarker can do, and you again saw a little bit of this already, is be what's called a surrogate endpoint. And what does that mean? That means some reflection, again, of a biologic process that tells us how somebody is doing in a clinical trial or during treatment. Meaning it is an early signal before we can see something else going on in the patient that somebody might be responding to a drug or not responding to a drug. And so when we talk about clinical trials and using biomarkers, that's kind of what we're interested in. Can we look at something 6 weeks out or 8 weeks out instead of the 12 months out that you heard about already? That might tell us an early signal of who might be responding or not responding to a treatment. So when we talk about biomarkers for a clinical trial, that's what we're talking about. So what would be ideal? Like if we had like a perfect test that we could draw your blood and we could know a lot of different things about your scleroderma and about these issues about, is it active, is it progressing? So we would have a simple test that would tell us, is there activity or progression? That would be great, because it's actually hard for us to discern that sometimes on our own clinically. And the perfect biomarker would have something to do with what's causing trouble, right? It would be modifiable by treatment, and it would predict what's going to happen without treatment. So that would be perfect. So that's what we're looking for. That is our ideal goal. We don't have a marker like that yet, but there are many, many areas and many investigators who are looking at this. And as we'll talk about it, as you heard a little bit in the clinical trial talk already, if we incorporate some of these biomarkers into these trials, we will really get closer. And if we have drugs that work, that's important too. When we start to have drugs that are working, we can have these potential biomarkers for endpoints. So what is the value of a biomarker? So if you take a disease state where somebody is somehow predisposed, say genetically predisposed to a disease, and we know that sets off some biologic process that may start before a patient feels symptoms or before they have anything recognizable. And this is true for the onset of disease like scleroderma, where there might be something going on in the immune system before a patient presents or before a physician recognizes that they have scleroderma. But there might be something measurable there. And this also is true if you take a complication of scleroderma like pulmonary hypertension, where a subset of patients will develop pulmonary hypertension, but there probably is some process going on beforehand that potentially is measurable. So the goal would be that if we measure biomarkers here of this biologic process, that potentially we could move therapy to an earlier point in the process, and we think that patients will do better. And I'll actually show you some data that suggests that that's true, that if we catch things earlier, that we can really improve outcomes. You are not meant to be able to read this slide. I put it up there on purpose, just to explain that this is a list of all different complications that can happen in scleroderma and the percentage of patients who get them. And the point of the slide is just to say that this disease is very complex and very heterogeneous, meaning your scleroderma is different than the next person with scleroderma is different than the next person with scleroderma. And as already suggested, this makes it actually a little tricky for us to study from a clinical trial standpoint, because we always would like to be comparing apples to apples, right? And so when we perform clinical trials, we have to keep in mind that not everybody is going to look the same. But that also means that there is not one uniform progression. And there are really just subsets of patients who are going to develop some of these complications we're going to talk about. And when I'm taking care of a patient, trying to figure out one patient, like what's going to happen to you when I see you, is what I really want to do when we're taking care of a patient. Understanding this at the group level is what we really need to do from a research standpoint, so then we can select patients better for trials. We can better predict who's going to need a treatment for a particular manifestation of the disease. So it's crucial for us when we investigate new therapies to understand this. And biomarkers really could probably play a role in both understanding an individual's patient course and this group level clinical trial questions that we're trying to answer on the research side. So I'm going to talk a little bit, we're going to incorporate a little bit of Scleroderma 101 just to kind of make sure we're on the same page, and talk to you a little bit about what we call phenotype. What does that mean? That means an observable characteristic of disease. That means kind of what does your scleroderma look like compared to the next patient with scleroderma? What do we say? What do we learn about what kind of disease somebody has? Because truthfully, right now, these are probably some of the best markers we have of what's going to happen to somebody's scleroderma, what the skin looks like when somebody presents, what antibody you make, what the CT scan at baseline looks like, are some of the best markers we have right now for us to understand what might happen going forward. So if you can do that really well, that is helpful. It's probably not sufficient, and that's why we're looking at other markers to help us along. But if we combine that with other markers like genotype, like molecular markers, like these biomarkers, not only will it help us do this better, which is going to help everybody on an individual patient level and for clinical trials, but it's probably also going to teach us a lot about the biology of the disease. If we find that perfect biomarker that is reflecting some biologic process that is relevant in scleroderma, that molecule may be a target for treatment in addition to being a biomarker. So one of the most common ways that we do this, that we say what kind of scleroderma does somebody have, is by looking at the degree of skin involvement. And we subdivide patients with scleroderma into two subsets. One group that has diffuse skin disease, meaning skin disease that is present in large areas of the body, versus patients who have limited skin disease in a restricted distribution, almost always just restricted to the fingers and the hands, and sometimes involving the face. And we know that by doing this kind of subsetting by how much skin disease there is, that tells us something about what might happen. Patients who have diffuse disease are at higher risk for things like scleroderma, kidney disease, and progressive lung fibrosis. But it's not great. Just this subsetting alone is not sufficient in terms of what we would really like to do, which is have kind of individualized recommendations for treatment and trying to predict what's going to happen. A better way that we do this is by looking at scleroderma-related autoantibodies. So as you know, this is an autoimmune disease, And that means that we can detect in the blood of patients who have scleroderma an antibody directed against self-protein. And in scleroderma, there are very specific autoantibodies associated with it. And what's fascinating on the research side, and that helps us in the clinic, is that these antibodies are very distinctly correlated with what might happen to somebody's scleroderma. So, for example, people who make RNA polymerase III antibodies almost always have diffuse kind of skin disease and usually rapidly progressive skin disease, and seem to be particularly predisposed to having scleroderma kidney disease. So this, in a sense, and we'll talk about this a little bit more, this is kind of one biomarker that we have for what might happen, as opposed to patients who have centromere antibodies, which associates with what we used to call the crest syndrome, which means limited skin tightness, but more risk for vascular complications. And SCL70, which associates most strongly with lung fibrosis. So this hones in a little bit better if we know somebody's autoantibody to say, okay, this means something to me as a clinician to say, okay, if I see somebody who has this antibody, this is really what I should be thinking about. This is also important for clinical trials as well, because if you're looking at a drug for skin, you really want to include people who are really going to have progressive skin tightness to really understand if the drug is going to work. So then we can say, okay, let's take everything we know from all of these things. How long has somebody had scleroderma? What kind of skin disease do they have? What is their antibody? What do their lungs look like? Or their radios look like? It's at baseline, and say, okay, if I synthesize this is going to kind of tell me a little bit about what might happen. And this is where we could add biomarkers to say, okay, so I can see some of these things, and this helps me to some extent, but if we add this layer, it's likely that that will enhance this even a step further. And so these are some of the big things, but as you've heard already, there are other things that we can measure too, so you can get this really kind of complex array of organ involvement or complications of scleroderma to really hone in on this better. So I'm going to use an example of a patient to kind of talk about a few of the main complications of scleroderma in areas where we're looking at biomarkers. So this patient is a 45-year-old woman who was well until the fall of 2016, and then developed new cold sensitivity and Raynaud's phenomenon, quickly followed by swelling in the hands and feet, and then subsequently progressive tightness in the skin. And by January 2017, when she was evaluated, it was noted that she had skin tightness in the fingers, hands, forearms, and feet, with a modified Rodman skin score of 14, which is kind of moderate to significant skin tightness. That she made these RNA polymerase III antibodies. Her lung function data suggests that she had pretty preserved lung function and had very mild amounts of scarring in her lungs. So when we see a patient for the first time, as a clinician, we say, okay, do I have to worry about this patient developing progressive lung fibrosis? What's going to happen to the skin? Should I offer treatment right now? Is it reasonable to observe? And then what else should we be worried about and what might happen next? So I'm going to start with what might happen to the skin and should we treat, and use it to talk about what we know about this. I already told you about how we very broadly think about skin tightness and scleroderma, and when we're talking about the trials and treatment for skin disease, we're really talking about this subset, which is about a third of the patients that we see with scleroderma. Patients who have very mild skin disease, again, usually just restricted to fingers. One, we don't think that really responds to therapy, and two, isn't going to change, so probably doesn't really require the immune suppressing or other strategies that we would treat diffuse scleroderma with. As you've heard already, we assess the skin by doing what's called a modified Rodman skin score. So many of you have had this assessment where the doctor pinches 17 body areas of the skin to get a sense of what the thickness of the skin is. And this has been the outcome measure for most clinical trials for skin disease and scleroderma to date. It has some problems. It is not a perfect assessment. It's a little bit subjective, and what I score the skin as might be a little bit different than Professor Denton or Dr. Varga, just because it is subjective. And it's also not specific, so it's not really telling us something about the activity of the disease necessarily. It might reflect severity of disease, but not necessarily activity. So the skin could be tight, but it might have been tight for a very long time. And that person's skin might score the same way as somebody whose skin just became tight and is progressing. So, and then the important problem for a clinical trial standpoint is that it is not sensitive to change in short intervals. Well, what does that mean? That means you can tell me that things are getting better before this skin score will change. And I'll get the sense that things are getting better before I can measure it by pinching your skin. So that's kind of a problem, right, from a treatment and a trial standpoint, that there are signs that people are getting better before this measure changes. So what if you take a group of patients who have diffuse skin disease, what's the history of that? What would happen if we didn't treat? And we know that left even untreated, in most patients with diffuse scleroderma, the skin will gradually improve over time, which actually makes this a little tricky from a clinical trial standpoint, and importantly, why we have to have a control arm in clinical trials, because we need to be able to measure a drug against what we think is the natural progression of the skin disease. So this is, all these graphs are a modified Rodnan skin score, and this is time. And so we do see in untreated patients with diffuse scleroderma that the skin will change, will improve some over time. You actually already saw some of this data from Professor Denton that shows that even though on average the skin score improves over time, there's a lot of heterogeneity. So some people who start very high don't seem to get better. People who start high but do seem to get significantly better, and people start off a little bit lower and seem to improve. So again, we're working to try and identify, well, what differentiates everybody? If these two people look the same to start, like how do we discriminate this person from that person? And similarly, in treated trials, this is an experience we have looking at cell sets, not in a trial, but retrospectively in our center, and some of the old clinical trials for drugs in scleroderma, we see that, again, there is this kind of just tendency to improvement, where we do over time, we think, with some treatments, see this modest improvement in skin. And this is one of the drugs we use standardly, not a robust change at 12 months, and again, probably reflects the fact that the skin score is a little bit slow to change when we measure it, even if we think people are getting better. So how do we predict this better? So that we know that what your antibody profile looks like is very likely to tell us about what might happen to your skin. So patients who make RNA polymerase III antibodies tend to have very rapidly progressive skin disease. But the good news of that is when patients get better with this, they tend to have this similarly kind of steeper decline in terms of their skin score. So if they're going to respond to treatment, they seem to do it quite well, whereas other groups don't get quite as high and have this kind of more slow progression or improvement over time. And this is data from our center where we looked at large groups of patients over time just to show you kind of pictorially what happens to the skin score when you look at particular antibody subsets. So this is again skin score here. This is 6 different groups of patients grouped together by how their skin score changes over time. And the more blue dots you see, the more representation there is with this antibody RNA polymerase III. So you can see that the people who have very high skin scores that don't seem to get better, much more often are in this group of RNA polymerase III. Although there is some here in people, again, who start with high skin scores who improve. So again, we would really love to discriminate, and there is pretty much equal treatment, between these 2 groups. We would love to discriminate, maybe with a marker in the blood, ideally, what discriminates this patient from this patient, because that would be really important for us to understand, which drugs to offer patients, or, when we're trying to figure out, who to put into a clinical trial, that would be important. This is just the same kind of graphic, now looking at a different autoantibody called SCL70. This antibody is one of the more frequent antibodies in scleroderma, and we traditionally think of it as being associated with diffuse skin disease. As you can see,
there's patients here with this antibody, there's patients here with this antibody, there's patients here with this antibody, and there's even some hidden in here, and it's a little harder to see. This antibody is much more variable in terms of what happens to the skin amongst patients who make this antibody. Again, important for us to understand these differences when we're trying to assess a treatment going forward, where some of these kind of risk is going to start. So what about biomarkers? So we don't have a perfect biomarker at this point for skin disease, but there are certainly some things that are being looked at that might be promising. So there's a marker called CXCL4, which is what's called a chemokine. This is a marker that's measurable in the blood, that's secreted by cells, that goes around and is kind of influencing cells to do different things. And what does it do? It inhibits blood vessel growth and stimulates scar formation. So that seems important in terms of relevant pathways. And it correlates well with the skin score, meaning if this marker is high, the skin score is typically high. And importantly, levels of it seem to predict development of worsening lung and skin disease, and may help patients identify patients who are more likely to respond to treatment. So this is one that maybe has a little bit more data. There are many out there. I'm giving you just a few examples. But this is the kind of work that our people are doing. Does this seem to relate to the underlying biologic process of the disease? And does it change with time? And does it help us discriminate who might respond to treatment? You already heard a little bit about some of these gene scores or gene signatures. So this is measuring what's called gene expression. So you measure thousands of genes, and are they kind of being turned on or turned off, or expressed at high levels or low levels? And this data is ascertained mainly from skin biopsies. And then if you get these combinations of genes that either discriminate scleroderma from healthy controls, or importantly, genes that are getting turned on or turned off with treatment, that may be something that could be one of these intermediate endpoints. And you already saw that in one of the clinical trials that Dr. Benton presented, that these may be early indicators of what might be happening with the skin before we can see it, before the skin score is changing. So this correlates with skin score, and changes in this gene score seem to correlate with changes in the skin score both with and without treatment. So that suggests that this might be actually a very useful strategy. And here's just the same kind of representation of what this might look like. You subdivide patients clinically up here, and then you look and see what the genes are. These are healthy controls. They're different subsets of scleroderma. Clearly, their genes are doing different things. And then you can measure pre- and post-treatment to see what happens to these genes going up, going down, and might reflect who's going to improve. So where could we use biomarkers in terms of the skin? Sometimes we have trouble understanding if someone comes to us the first time and they have some degree of skin thickness, if this is an active process or the kind of activity of the disease has already kind of slowed down. So it would be helpful for us, again, to predict who might be at risk for continuing to progress, to understand that skin activity and have something that predicts who might worsen and who would be a good candidate for treatment. And importantly, and probably more importantly for the skin, to predict earlier who's responding and not responding to treatment, because that will help us individualize treatment going forward when we have drugs that we think are working. So for our patient that I presented, so what would we say? That they have early disease and they make this RNA polymerase III antibody and they already have a moderate degree of skin involvement. We would say that that patient is at high risk for progression of their skin disease and certainly should receive treatment directed at improving skin progression and should be a candidate for trials of new therapy. So go back to our same patient again. And so what else should we be worried about? So we alluded to this already, but one of the things we should be worried about is scleroderma kidney disease in a patient with early diffuse skin disease who makes RNA polymerase III antibodies. This is something that's used to, before the advent of effective therapy, was universally fatal in scleroderma. So before we had the blood pressure medicine called ACE inhibitor, this was a very bad problem in scleroderma that led to death. Even today, after ACE inhibitor development and use, People still end up in dialysis, either temporarily or permanently, and may have early death in renal crisis. So this is still a very important problem in scleroderma. But this is an area where we kind of know that there seems to be particular risk factors. So on the clinical side, if we're looking at who we think might be a risk for this, this seems to be much more of a problem in subsets of the disease. So people who have diffuse skin disease with rapid progression for less than 4 years from disease onset, we think that African American patients seem to be at a higher risk for this. And what we certainly know is that RNA polymerase III antibodies, where 25 to 30% of patients who make this antibody will have a kidney issue at some point in their disease. This is one of the strongest markers that we have for somebody who might be at high risk for this. Interestingly, other things that we could measure, like what your blood pressure is at baseline, other antibodies, what your urine test looks like or your kidney function looks like at baseline, none of these things are very predictive of who's going to develop kidney problems. So this is an area where our biomarkers are really the kind of scleroderma somebody has and this antibody. And then we use that information to say, okay, we really need to target screening in this group of patients much more than in other groups. So just a word about these antibodies. Depending on where you live, it may be up to 20% of scleroderma patients. Here in the US, it's about 20%. In other countries, the rate of this antibody is much lower. Again, it associates with the most aggressive kind of skin disease, and 15% of their patients, their skin tightness comes before their raynaud, which is almost always the first manifestation of scleroderma in just about everybody else. They are the highest risk for this kidney problem, but actually lower risk for significant lung fibrosis. So this is an area, again, our patient, rapid progressive skin disease, early disease, that makes this, what we have is kind of a biomarker for this is RNA polymerase III antibody. So what do? We educate our patients about looking for early signs of this and ask them to start monitoring their blood pressure very closely and develop a very clear plan for what happens if the blood pressure reading is abnormal, because if we catch it early, we know we can improve somebody's kidney function long term. Okay, let's go back to our same patients who we think is at risk for progressive skin disease. We're worried about development of kidney disease. What about lung disease? Do we have to worry about this in our patients? So this is a picture of what scleroderma lung fibrosis looks like. Air should be, the lungs should be mostly air, like in this picture, and the scar tissue is kind of getting in the way of normal lung processes. So what do we know about lung fibrosis in scleroderma? Just about everybody will have some degree of lung fibrosis, which surprises people, I think, because we actually don't need to treat most patients who have lung fibrosis because they are not all likely to progress. Only a subset of patients are going to progress. But if this is progressing, this is a problem because it leads to limitations of activity and shortness of breath, and potentially need for oxygen use, and in the worst cases, potentially need for lung transplantation. So this is what we know from a clinical standpoint and who might be at risk for this. I had mentioned earlier that people who make the SCL70 or topoisomerase antibodies seem to be at particularly high risk for this, as some of the other less common antibodies also seem to be at risk for this. Patients who have diffuse skin disease seem to be at slightly more risk than people with limited skin disease. And what your lung function and CT scan look like at baseline does tell us something about what the risk is for progressing. So right now, what we do in the clinic is we kind of take an assessment of all these things. What is somebody's antibody? What does somebody's skin look like? What is their baseline test? And say, do we think this person is at risk for progression? And this gets us, again, part of the way, but not perfect in terms of really being able to, on an individual level, predict what's going to happen. So we're going to go back to this picture again. So what does this tell us? So if you have diffuse skin disease, what does this tell us about what your risk is for lung fibrosis? And actually, this is not so great. So on average, we think the risk of progression is a little bit higher, but this is not so great. So this is data from the Scleroderma lung study 1, looked at Cytoxan versus placebo, which showed that Cytoxan had some benefit for treatment of lung disease at 12 months. And this is what happened to the people who got cytoxin, and this is what happened to the people who got the placebo arm. They had decline in their lung function over time if they got the placebo. And this is subsetted by the type of skin disease they had. So this is limited, and this is diffuse. And as you can see, they both pretty much responded the same way, both in terms of their response to the treatment, but also if you didn't get treatment, what happened to your lung function over time. So the skin tells us probably only very little about what's going to happen. The antibody that I told you about, the SCL70 antibody, which we think of as actually being a strong correlation to lung fibrosis. This is data from our center. That's what's called a spaghetti plot. You can see why it's called a spaghetti plot. This is lung function, and this is time. So these are people who don't make this antibody and people who do make this antibody. And you can see that there is, on average, people who don't make this antibody tend to, on average, stay stable. People who make this antibody, on average, tend to lose some lung function. But would you feel reassured by this? Look at these. It's all over the place, right? Some people here do really well, some people here do really badly. So, again, it helps us a little bit, but not as much as we would like. So what do we know about other biomarkers for progression of lung disease? So there are these two markers called SBT and KL6 that are proteins secreted by lung cells. And we know that in a cross-sectional way, these markers can correlate with lung disease severity, other markers that we measure clinically, like what the pulmonary function test looks like. So there is some correlation. It has not clearly predicted lung function decline. There's been some variability in how well these seem to predict what's going to happen going forward, and we don't know yet that these markers really indicate somebody who's going to respond or not respond to therapy. There are some of these what's called chemokines that have been looked at as well. This is the same one that we talked about when we talked about the skin, CXCL4. In Scleroderma lung study 2, which looked at cytoxin compared to CellCept for people who had active lung disease, the levels in both groups went down with treatment, and both groups responded to these treatments in terms of their lung function. And it did seem that changes in this level at 12 months predicted what was going to happen both at 12 and 24 months. So this is, again, promising as something that might help us and an early marker of what might happen going forward. Another chemokine called CCL18 correlated with short-term but not long-term decline in lung function, but high levels associated with decline in lung function and progressive fibrosis on CT in another study. So just so you know, most of these trials that are going on for lung disease now are examining some of these biomarkers, because as we again get therapy that we think is effective, understanding what happens to these biomarkers during the course of the trial are really going to help us going forward to know who's going to progress and who's going to respond to therapy. So in terms of how we might use biomarkers in the lung, we'd like it to predict short and long-term progression of lung fibrosis, to identify patients for treatment and for clinical trials, and predict in the shorter term who might be responding to treatment. So just like the skin, this might help us in clinical trials earlier than our other measures, because for our trials for lung disease right now, we're talking about 12 and 24 months of observation to see changes in the lung function test. So it's a pretty long time to go on a treatment not knowing if the drug is actually helping us or not. So to go back to our patient, so this patient again, early diffuse scleroderma with RNA polymerase III antibodies with normal, nearly normal lung function tests at baseline. For that patient, we probably wouldn't give treatment for their lung disease, but we would monitor them closely, like we do in all patients with scleroderma with regular pulmonary function tests. The last area I'm going to talk about is pulmonary hypertension. So this is a blood vessel problem where there is narrowing in the circulation of the lungs, which then, because of this pressure of backflow into the right side of the heart, puts strain on the right side of the heart. And just to somewhat simply try and explain a very complex process, pulmonary hypertension and scleroderma probably isn't one thing. It's probably multiple things. And even though a small, relatively small subset of patients with scleroderma get pulmonary hypertension, amongst those patients, it's probably not the same necessarily from person to person. So what we think of traditionally as pulmonary hypertension, like I said, is a lung blood vessel problem that leads to backup of pressure in the right side of the heart. But what we know is that for patients who have lung disease, who have scar tissue where the air is supposed to be exchanging, this predisposes people to a type of pulmonary hypertension as well. And there is a small subset of patients with scleroderma who have left heart trouble. This kind of system works kind of this way. So if you have pressure back in the left side of the lung, or left side of the heart, this can cause a pressure back up through the lungs and ultimately to the right side of the heart. And so when we're seeing somebody with scleroderma as pulmonary hypertension, there actually may be all of this kind of complexity going on in an individual patient or varying from patient to patient. So let's walk through a case again. So this is a 52-year-old woman with limited skin scleroderma who was first seen in 2013. She had symptoms going back quite a number of years prior to that, with joint pain since 2001 and rheumatoid since 2005, complicated by ulcers, and makes this anti-centromere antibody. And when she was first seen in 2011, she seemed to have this kind of mild but stable shortness of breath, not really limiting. But because of shortness of breath, went through a series of tests, including a stress test and a CT scan of the lung, and didn't have evidence of heart problems, had very minimal lung scarring, and had echocardiograms done to look at this pressure serially over a 2-year period of time that suggested that the pressure was normal. So still came in with shortness of breath that seemed to be unchanged, otherwise she was feeling well, but because of this persistent shortness of breath, referred her to our pulmonary hypertension colleagues who did an exercise echocardiogram that suggested the pressures were not in fact normal, that they were elevated, and had a right heart catheterization that confirmed pulmonary hypertension. But here's a patient who had come in and said for years she had had mild shortness of breath that wasn't changing. And she was started on therapy. And so what's important to see here is that this patient, this is two different tests within the lung function test. This is the FVC, which is the one we measure to see what somebody's lung scarring is doing. This test over years was totally stable. But this is the DLCO part of the breathing test. This measures how well oxygen is exchanging. And from the first time it was measured, it was not quite normal. And it was slowly declining over this period of time that she was feeling a little short of breath, but actually not changing over time. There were measures there that told us something was going on. And so when we think about a complication like pulmonary hypertension in scleroderma, we think that probably, like that slide I showed you earlier, that there is this kind of long preclinical vascular disease. So from the time somebody develops signs and symptoms of scleroderma, they may or may not get this scarring process early on, but there is probably this kind of ongoing vascular insult, at least in a subset of patients. And like pulmonary hypertension, what seems to occur later, this seems to happen more frequently later in the disease. And that DLCO kind of was a sign that this was happening. We know that pulmonary hypertension within scleroderma is a significant predictor of survival. So now this data is a little bit old, and this is an area that's changing, but suggests that if people develop pulmonary hypertension, it's significant. But what I want to focus on is this study that came out of France that suggested that if we put patients on a regimen of aggressive screening for pulmonary hypertension, which usually means they get identified earlier as having pulmonary hypertension and on therapy faster, that this really improves how well somebody does. So this is a survival curve in terms of people who are in this more aggressive looking for pulmonary hypertension as compared to people who were not. And so this does tell us that if we look carefully and see these early signs, we get people on therapy, that this can improve how well somebody does. Once somebody develops pulmonary hypertension, we know lots of things that might tell us about who's going to progress. That's important for us to understand too, but what I think really is the opportunity is that we really like to take advantage of the fact that we think there's a blood vessel insult going on for years prior to allow us to start identifying patients for therapy earlier. You probably know this, but there are now 14 drugs approved in the United States to treat pulmonary hypertension. So if we can identify patients earlier, then that would really help us get them to therapy faster. So what do we know now about risk factors for pulmonary hypertension? We know that if you have late onset scleroderma, meaning you develop scleroderma at a later age, that seems to increase the risk. People who have other blood vessel problems. And importantly, we're going to talk about the diffusing capacity that I just showed you and a marker called proBNP. Antibodies are not quite as helpful to help us predict pulmonary hypertension as it is for some of the other complications that we talked about. This just shows that if you take patients who develop scleroderma at an older age, in this study 65 and older, that the risk of pulmonary hypertension goes up faster than if you develop scleroderma at a younger age. And we did a study showing that if you have other blood vessel problems, this is the telangiectasia, the T in the Crescent syndrome, patients with larger numbers of telangiectasias have higher rates of pulmonary hypertension, again, suggesting that there's this ongoing blood vessel problem that's possibly measurable. I showed you already that people had a low DLCO years before they were diagnosed with pulmonary hypertension. That tells us that there is a biologic, probably a measurable biologic process going on before somebody clinically comes to us with pulmonary hypertension. And this proBNP, which is a marker of stretch or strain on the heart that is measurable in the blood, is also elevated before somebody clinically presents with pulmonary hypertension. So both of these, the proBNP and DLCO, are things that we are using clinically now to help us find that person who is going to have pulmonary hypertension. So we can pick it up early. But what we would really like, so these are telling us that something has already happened. This is measuring stretch on the heart, it already happened. We would really like to find something earlier. So I'm just going to again show a couple of levels. So this is a oligopolygon. And this has been shown to associate with vascular disease across the board. So this is data from our center that suggests it's higher in patients with pulmonary hypertension. It is higher in patients with more severe rheos. It associates with this DLCO in the lung function test and associates with centromere. So it seems to tell us that something is going on. And this is another one called placental growth factor that people have been interested in, including our group, that suggests that people, even before they were formally diagnosed with pulmonary hypertension, had elevated levels. And this is again data from our center that suggests that the levels are high in patients who have pulmonary hypertension. So we do think, and interestingly, both of these molecules are already known to be excellent biomarkers in predicting preeclampsia in pregnancy. This is a vascular problem, complication of pregnancy. So, which is why we find, part of the reason why we find them particularly interesting. So pulmonary hypertension tends to occur later, but has this long preclinical phase. And biomarker development here should really focus on pushing us much earlier in terms of protection. And then treating early likely to improve the outcome. So I'd like to finish by saying that I think the progress has really been incredible in the past few years, both in our clinical abilities to predict progression in scleroderma and development of biomarkers. And we think that even though not one of them is perfect yet, that they're really going to play a role in us doing better going forward and help us understand the underlying biology and help us understand who's going to progress in early detection. But the trials that are underway now are really going to be kind of the gold mine, I think, for biomarkers. So if we have drugs that are effective and we study these biomarkers in the context of these studies, we're really going to understand what these markers are trying to tell us, and we can use them going forward. And so biomarkers have really been incorporated now into all the clinical trials that you've heard about and going forward. So I'm going to end there and say thank you to John again and to the Chicago chapter of the Scleroderma Foundation. And I hope we have a few minutes still for questions. Thank you.